service package?
Yeah.
Yeah, of course. So, and which university was it in Canberra?
La Trobe.
Oh, La Trobe in Melbourne.
In Bandura.
Oh, okay. Yeah. My gosh, you know this country better than I, sir.
Yeah. I stay in national park near national park.
Yes. In fact, out of all of our states in Australia, Victoria, in particular Melbourne, has been the most affected by the COVID, and they have had a very strict lockdown. No other Australians could go into La Trobe, and no La Trobe people could come out. So we're very pleased to nearly eliminate that now.
Izin Pak Dekan, mari kita mulai acaranya. Good morning, greetings to our guest international keynote speaker, Mrs. Lou Robinson, the Director of Institute Training, our Honorable President of General Ahmad Yani University, Professor Hikman Hanto Juwana, the Dean of Unjani Medical Faculty, Dr. Sutrisno, Vice President of General Ahmad Yani University, guests and representative from the Indonesian National Board for Disaster Management, the Regional Board for Disaster Management, all the professor, senior rectors and doctors from Unjani Medical Faculty, all the lecturers from Educational Hospital, and as well as our beloved alumni and student and webinar participant. First of all, may we thank God that we can gather here today and meet online in this webinar event and stay healthy amidst the pandemic situation. Allow me to introduce myself. My name is Dr. Terry. I'm the host for today's webinar. For today is the third day in the webinar series with the theme of Road to Vision for socialization of the vision and mission of Unjani Medical Faculty. That is to become a faculty of medicine that is able to compete at the international level, has a national spirit, and has an environmental perspective in the field of medical emergencies in 2035. The goal of this webinar series is as a socialization of Unjani Medical Faculty's new vision and mission to the academic community, and as an initiation point for cooperation with various institutions, both national and international, related to the implementation of this new vision and mission of Unjani Medical Faculty. And also as a strategic step in implementing the Unjani Medical Faculty vision and mission in the field of research, community service, education, and academic atmosphere. On the first and second day, we have socialized the vision and mission to the lecturers, alumni, and medical students. For today's webinar agenda, we will have disaster management course, and the topic is emergency preparedness and disaster response during pandemic of COVID-19. We will start the webinar today with the opening remark from the Dean of Unjani Medical Faculty, Dr. Sutrisno. Dr. Sutrisno, please, the time is yours. Dr. Sutrisno, please, you can give the opening speech.
Sudah dengar ya?
Sudah. Oke, sekarang dengar.
Oke ya. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning everybody. Selamat pagi Pak Rektor. Selamat pagi Miss Lee Robinson. Good morning. First of all, I want to say thank you to Mr. Andri and Mrs. Sylvie to perform this webinar. This is the serial webinar, 3 days webinar. On Friday, we have a webinar with our lecturer, and Saturday we have a webinar with the student, and now we have a webinar for all. In this morning, we have 2 speakers. First is Miss Lo Robinson, is our keynote speaker from Insight to Training. And secondly, Mr. Berton as our speaker from Indonesian National Board for Disaster Management. As you know, we have a vision, our faculty vision, but normally the vision is very good, but the implementation, we have the problem about the implementation. Less implementation. This is our medical faculty new vision, to be the medical faculty with international recognition, especially in emergency medicine, that improve the community services in 2035. To be aligned with the faculty vision, our medical study program has a specific vision as follow: to have graduates with international recognition in emergency medicine that improve the community service, especially disaster management in 2035. In order to have a strong and continuity in the implementation of our vision, we try to embed the emergency skills as well as disaster management in our education program, research, and also community services. This implementation has to be supported by a national and international collaboration. In national collaboration, we have collaboration with military hospital, Gatot Subroto Military Hospital, and also the National Board for Disaster Management in Indonesia, namely BNPB. Internationally, we have an initial project for collaboration with Insight to Training, which has a mandate to strengthen the emergency preparedness and disaster response capacity of government and civil society actors throughout the Asia Pacific region. I know Insight to Training from Mr. Andri, and I believe that Insight to Training is a good institution and have expert in medical emergency. So that's why we invite Miss Lo Robinson from Insight to Training to this webinar. Hopefully, someday we have a collaboration, and someday we can send our student and our lecturer to study there and work together in university. And someday we hopefully we can invite Ms. Lopez to come to Indonesia. Okay, thank you.
Thank you, Dean.
Thank you. I think that's all.
Okay, thank you very much, Dr. Sutrisno, for the opening remarks. We hope we can implement the vision and mission of Unjani Medical Faculty, and we can have many national and international collaboration with other agencies and institutions. For the next, we will have opening remark from the president of Unjani Unjani from Jenderal Ahmad Yani University, our honorable president, Professor Hikmahanto Juhana. Please, you can give your opening remark. The time and place is yours.
Well, thank you very much, Terry. Hi, everyone. Assalamualaikum warahmatullahi wabarakatuh. I hope all of you can hear me. I'm doing my routine exercise, and at this moment I'm at the Ragunan Zoo. And it's an honor for me to open this webinar, and I welcome the initiative from the Faculty of Medicine in conducting this webinar and inviting Laura Robinson from In Situ Training Center so that we have an international collaboration. I, as a new rector at the Universitas Jenderal Ahmad Yani, I was installed since April, have a big task, which is mandated by the Chief of Army, who the Army owns this university, the Indonesian Army, that is. Now, I would like the committee, if you have prepared the video of our university so that our audience can see what is being envisioned by our Chief of Army. Can the committee start the video?
Saya ingin Prof. Unjani di Indonesia harus menjadi Naval Postgraduate School di Amerika.
Unjani sudah saatnya untuk take off, sudah saatnya untuk maju. Kita harus bisa mengejar ketertinggalan kita. Makanya ICT ini kita bangun, kita paksakan. Tapi pada saat yang bersamaan memang kita pun harus memperbaiki fisik Unjani, fisik.
So that's is going to be our new campus, our university. The Chief of Army is going to launch this new campus in 22nd of December of this month. And we hope that the construction will start on January. There are two things that the Chief of Army mandated to me. First, he wants the university to become the same as naval postgraduate in the US. The naval postgraduate is in Montreal, and I look at the Google and the population there, and I see only of about 28,000 population. While we, even though we are considered as a small city in Indonesia, in Cimahi, but we have more than 28,000 population. But even though we are located in Cimahi, like Naval Postgraduate is located in Montreal, but we have to internationalize ourselves. We have to make our university known, not only nationally, but internationally. So this is why I welcome the initiative from the Faculty of Medicine to have this webinar. And I hope next time around, Laura Robinson will come to Cimahi and see our university once it's ready. Secondly, the Chief of Staff mandated to me that the education at our university is going to be at the same level as other international university. This is why the Dean of the Faculty of Medicine have been struggling with my request. For example, to make the faculty develop. For example, the Faculty of Medicine is going to separate its what we referred here as a Prodi or Department of Dentistry to become a faculty. So hopefully we're going to have that. And then also we're going to have a master program on hospital administration. And also we're going to have our faculty to have a specialist program. So a lot of initiative is going to be made within the Faculty of Medicine. And Laura, for your information, we have a splendid university. We have the best students at our Faculty of Medicine. We can gather from all over Indonesia to come to Cimahi and study medicine at our faculty. And we are very proud that our alumni have been accepted in various institutions, including the military and of course the army. And I hope to continue that level of students and alumni. And last, I would like to thank the In-Situ Training Center for having a cooperation with us. The issue that is being discussed today is very important. Two things: the emergency preparedness, and secondly, how we're going to respond on disaster. And at this moment, we're going to discuss on the issue of the COVID-19 pandemic. We have been struggling, but if you look at various institutions, I think the Army is well prepared in having or in responding to the emergency situation of the pandemic COVID-19. And you can see at their Instagram or social media on how the Chief of Army is gathering the medical doctors of the Army to assist the Indonesian government in coping with the COVID-19 pandemic. So I hope that we can learn from you In-Situ Training on how we are going to prepare ourselves in emergency situation and also to respond the disaster. And secondly, of course, we have people from Satgas who may also give their take on what they have done in responding to the pandemic COVID-19. All in all, I hope that we can learn and then we can strengthen ourselves in preparing in every emergency situation. And Indonesia, we have been challenged by various emergency situation, and thankfully we can cope with the situation. So with this, I would like to officially open our webinar. And again, I hope that we're going to have a successful webinar. Thank you very much. And I have to continue my exercise. Regards.
Thank you.
Best regards.
Thank you very much, Professor Hikmanto. Thank you for a very inspiring speech and giving us the future goals of General Ahmad Yani University. I hope we can all achieve the goals that the Indonesian Chief of Army trusted to us, especially we in the Faculty of Medicine. We hope this webinar will be the starting point in the effort of achieving that goals. And for today's main topics is the disaster management course and emergency preparedness and disaster response during pandemic of COVID-19. We will have Dr. Andre Anugrah, the head of Unjani Medical Emergency Department, as today's moderator. The first topic will be given by our international speaker, Mrs. Rue Robinson. And the second topic will be given by Mr. Bertrand. Dr. Andre Anugrah, please, the time and place is yours.
So sorry, I have to leave first. Laura, I hope that we will have a good discussion on the issue. Bye-bye.
Thank you very much, Rector, and enjoy your exercise.
Thank you very much.
It is an inspiring vision, sir, and I can see that there is much scope for an Australian-Indonesian connection in terms of emergency disaster medicine. So thank you once again for an excellent and inspiring opening.
All right, thank you very much. Bye-bye.
Bye.
So let's start our today's main topic. Dr. Andre, please, the time is yours.
Okay, thank you. First of all, I'm so sorry with my bad English and to anybody. Good morning, ladies and gentlemen. Welcome to our webinar series today. Since we are currently in the middle of the pandemic, today topic is about emergency preparedness and response during COVID-19. And now we have here with us Mr. Louis Robinson, or we can call Lou, from Insider Training from Australia, who is going to talk about emergency preparedness and disaster response during pandemic COVID-19. She is a friend of mine and also mentor for disaster. We met in Honolulu, Hawaii 6 years ago during the Health Emergency Large Population course running by United States Army at that time. Good day, and how are you doing, Lou?
Good day, Dr. Andre.
Yeah, and we also have here Mr. Berton, PhD from BNPB. Pak Berton adalah Kepala Diklat BNPB ya. Selamat pagi Pak Berton.
Selamat pagi Pak Andrew.
Pagi ya.
Andri, maaf.
He will talk about disaster preparedness in Indonesia during pandemic COVID-19. And before we start the lecture from Lou, let me introduce Lou briefly about his background. Lou has more than 20 years experiences in international humanitarian operation with United Nations, with government, and with NGO. She served in the army, Australian Army, prior to this work, and she also worked in the United Nations World Food Program as professional emergency officer, and she also become trainer in all over the world, from North America, South America, from Europe, from Africa, and also from in Australia. She also trainer for Bill and Melinda Gates Foundation, trainer for World Food Program Learning Project, WHO training coordinator for West Africa in Ebola response, and so many more experiences. I think it's not enough time, maybe take more than an hour if I introduce all doing before. And I think I should stop here, and time is yours.
Thank you, Dr. Andre.
Yes.
Am I good to go?
Yes.
Okay. My CV, by the way, is very small compared to you all. And it was a pleasure to meet Dr. Andre at the invitation of the Center for Excellence in Disaster Management. And that is a facility of the United States Pacific Command. And it brought together different actors from all over the world, our Red Cross, Red Crescent colleagues, sitting with our military colleagues, and also our civilian counterparts. And to try and get a better understanding of how do we coordinate in a major public health outbreak, or in a situation where health systems are very weak as a result of a natural disaster. So although it was 6 years ago,
yes,
we haven't changed a bit. Okay, I'm getting a little bit more grey. Firstly, thank you, Dr. Terry, for a very nice opening and for welcoming me. I'm not sure if Terry and Andre, please help me if I am speaking too loud, too soft, or too fast, or indeed too slow, because my Australian accent can sometimes be a little difficult to understand. I am delighted. Sorry, is it okay? You just give me a thumbs up. Okay, great.
I can't hear you clearly.
I am delighted to be invited by the medical faculty of General Ahmediyani University to talk on these very big themes, which are emergency preparedness, disaster response in a time of COVID-19. Each one of those themes could be a standalone workshop in and of themselves. But I've taken a broad brush to the topic, and I'm exploring through what agencies involved in disaster preparedness and response in our region of ASEAN or Asia Pacific, how they are managing their programs during a time of a global pandemic. So I want to make it an interactive presentation. The theme is preparedness and response, but the tone is informal, and I will be making all efforts to pause and with Drs. Terry and Andre collate some of your questions from a large audience to see whether, and try and respond to the issues and insights that you have. Because I congratulate the medical faculty, these events provide an excellent opportunity to network, to exchange ideas and information on what actions and events unfold when a sudden onset disaster strikes, whether it be in your municipality, in your city, in your regency. So please take full advantage of each other by sharing your insights and your knowledge and your experience through the chat function, the chat function down below, where, as I said, a large audience, but we will be pausing throughout to try and collate some of those questions and make it as interactive as possible. I'm now going to pull up my PowerPoint presentation. There we go. Am I sharing the screen okay? Excellent, thank you. All right, so that's who I am. I am a faculty member of the National Critical Care and Trauma Response Facility. Now, this is an Australian government facility that was established at the turn of this century. And its focus is in Darwin, so it's the top of the country, and it's looking out to assist with our neighbouring nations. We have now what's called a Type 2 field hospital. So that is a fully self-sustaining, fully self-contained medical hospital in a tented facility that the government can use to respond to natural disasters. It's what we call a standby capability, and those with the military side, and I imagine that quite a few of you have that, understand that these terms are taken actually from a military context because they're extremely practical, and then they're being placed under a civilian lead. Very similar. Okay, the objectives for the interactive lecture this morning are these. I'd like to discuss with you some of the emergency preparedness trends and disaster response challenges across the region. We know that mounting a useful response requires coordination across whole of government, and that is more of a marathon than a sprint. And knowing where we fit in and how we can receive the information up and down that chain of command is critically important in making our response as effective as possible. But it's big. Whole of government is big. We'll also identify the health response actors involved in disaster response and how we set coordination at the outset of a disaster. And finally, we'll look at how for example, WHO, the World Health Organization, is working with ministries of health in Indonesia and across ASEAN in amalgamating incoming medical teams in a large disaster under a national leadership. So Indonesia is a strong country. It has strong disaster management legal frameworks. But if we do see a rupture of the Lembang fault line, for example, or another 2004 tsunami, there will be a need to bring in regional assets and even international support for overwhelmed local capacity. All right. And of course, we'll finish off with the COVID-19. This is an emerging reality in emergency preparedness and disaster response. And of course, it's just one of many emerging infectious diseases that has necessitated a paradigm shift in the way that we approach, traditionally approach the work that we once did. So we'll finish off with that. In the end, I do want to say we're doing this to be operational, because you colleagues, you form an important pool of clinicians and medical practitioners who become the crisis management team or the emergency response team for your institution when disasters hit. And your institution is relying on your knowledge and skill to strengthen their capacity to respond to natural disaster or public health outbreak in safe and acceptable ways, in meeting international standards and guided by international principles. And that's important for us because we respond in a way that reinforces the national government's priorities, not to undermine them. So the whole question of coordination is critical in this response. Okay, I'm going to start with the facts now. Asia Pacific is the most dangerous region in the world. This will not come as a surprise to you. For natural disasters, over half of the 4 billion people living in Asia, which is around 60% of the world's population, they live on or near the coastline, subject to tidal surge, sea level rise, and storm flooding. And people who live on the cyclone belt and the Pacific Ring of Fire are between 10 to 20 times more likely to be adversely affected by a disaster than the rest of the world. So your Indonesian action plan for disaster risk reduction backs this up. And what we know is that 1 out of 2 regencies or municipalities in Indonesia, 1 out of 2 are exposed to a high or very high risk of earthquake, that 4 out of 10 municipalities and regencies are exposed to a high risk of landslide, flooding, and drought, that one-sixth of all municipalities are exposed to high risk of tsunami and volcano. And compared to all the other major islands, Java Island is at the highest of exposure to all of those disasters. So it's extremely timely that we are talking about how prepared we are to respond to a shopping list of disasters, if you like, just to the north of here. Also, the World Disaster Impact. This is a report that's put out annually. The global hotspots for disasters remain Oceania and Southeast Asia. Southern Sahel and Central America are also, because of climate change and global warming, are also in a high risk category. Now, of the 15 countries most at risk worldwide, 8 are island nations. So the Solomons, Philippines, the Mekong, Vanuatu, Tonga, East Timor-Leste, Papua New Guinea, Kiribati, which you can see right out here on the right, Kiribati, have the highest under 5 infant mortality rate in the Western Pacific. They have no fresh water. They have deep salination problem for their breadfruit and their taro and tuber stock. So they're also food insecure. And based on current modelling, Tuvalu and the Marshall Islands will be underwater by 2070. Now, these are the canaries in the coal mine. Okay, these are the ones that are going to go down very quickly in our region and will be relying on big countries with a big response capacity to assist. You know, Australia, New Zealand, Indonesia, they are considered the big players in the region. It also means that planning and preparedness activities are critical to lessen the impact. And erudite decisions now are being made to invest in disaster risk reduction. Now, we know that disasters tend to seek out the poor and make sure they remain poor. There's a lot of vulnerability factors at play that affect vulnerable people in losing more in a disaster than those less vulnerable. And also that natural disasters are on the rise. They're more frequent, they're more intense, and more people are getting caught up. So the focus for governments now and the international community is to manage risk rather than manage disasters. It's simply more cost effective that way. For every dollar we invest in a disaster risk reduction activity, we save many, many more than much more is saved in an emergency response. So this is just one of several models, what we call the disaster risk management cycle. It may or may not be familiar with you. It's often described in 3 phases. So what we call the 3 R's, R for Romeos. The first one is the risk reduction normal phase. Just one moment. Now, the risk reduction normal phase is when we think of a hazard as outside of our control, but exposure or vulnerability we can control through disaster risk reduction measures. That's your preparedness, your prevention and mitigation. So this is the blue area, if you like, the normal risk reduction phase. When we think about preparedness activities, what we're looking at is public awareness campaigns, early warning alert systems, first aid training, sorry, colleagues, I've just got a little bit of a cough going on there. And mitigation activities are things like constructing surge walls against floods, retrofitting houses to reduce wind damage, for example, in the Caribbean, rehabilitating coastal mangrove forest. Many Pacific islands are doing that to combat sea surge. And then the next R we have is the response phase, the bread and butter, if you like, of many UN agencies and NGOs. And then the final is what we call our recovery and reconstruction phase. So this is very context specific. It's all about building or re-establishing line ministries, restoring sustainable livelihoods, building back better earthquake resistance homes, schools and institutions. And if you see down there in the post-disaster, it's also talking about reconstruction and relocation issues. Okay, now the length of each phase varies. You know, they're not distinct, they do merge, but as a general rule in Indonesia, you know, disaster response, it's 90 days, that's it. 3 months, and then after that, you're into the reconstruction and recovery. Now, the indicators that we would look for to determine whether we've moved from a response to a stabilisation is in basic survival needs. And that would be water, health, food, nutrition, shelter, you know, what public health or primary health response has been instigated. And much of our work is done there. That's stabilisation, you know, basic life-saving survival needs are met. And then from stabilisation to reconstruction, this is where T&I, you know, is a major part of connecting electricity grids, clearing airports, you know, getting the main supply routes up and running. So for an agency's perspective, the disaster is largely viewed as this cycle of response through to recovery. But from a beneficiary point of view, it can look something like this. We have some small response preparedness, and then the big one hits. Response, 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 a brief period of intense interest, and then back to normal. So we're going to examine this brief period of intense interest, which is the response to a disaster. It can look like a chronic crisis with acute exacerbations, if you like. And the response correlates to media attention, okay? Because the more coverage organisations get in the response phase, the more funding they receive. And so there is an intense competition to fly the flag, if you like. So who are these responders? The major players in a disaster response and humanitarian assistance. And what do they do for the health sector? Now, I expect that perhaps quite a few of you wear double or maybe even triple hats. So you have deployed regionally or nationally or perhaps even internationally. So please do feel free to share your experience and on you know, where you deployed and who with and what your role was. Of course, there is a multitude of actors in emergency health response in Indonesia. So let's find out who they are. And what I'd like you to do now is consider any of these following emergencies, okay, or any disaster response that you've been involved in the last year. Now, I've got tropical cyclone, I'm not sure if you pronounce that Sempaka or Kempaka. I'm sure you're aware of it. Now, that impacted the islands of Java and Bali with secondary impacts, including flooding and landslide. And then we had the Mount Agung volcano. Now, that's been rumbling away in Bali, causing evacuations into hundreds of centres. The Sulawesi earthquake, 7.5 magnitude earthquake off the coast of Palu, felt as far away as Malaysia. And of course, the ongoing COVID-19 outbreak, which some experts believe is yet to peak. And so who is doing what to minimize the impact of that outbreak and contain the spread of the coronavirus. Now, in all but one case, impromptu evacuation centres were stood up. The scale of the disaster overwhelmed the local capacity to distribute blankets, food, shelter kits, hygiene kits, etc. So the task, and this can be if you happen to be with somebody, you can do that in pairs, you can do this in trios, or you can do this independently. All you need is a paper and a pen. I'd like you to create a list of who the key actors were involved in that disaster. And then what did they do, okay, for the health response? So list all the health actors involved at local, district, Regency, provincial level. It could be public, private enterprise, the government agencies involved. Quick exercise, you can use your iPad, your smartphone, your neighbour, and jot those down. So that's part A. And then once you have all of those health actors, I want you to create an actor map, okay, of how they interacted. So who worked directly with whom, what sort of reporting hierarchy existed, and how did you fit in if you were involved in that disaster? If you weren't involved, just Google it and try and get an understanding of what coordination or hierarchy structures were involved, who was involved, and what they did. Now, your actor map on your piece of paper, you can use arrows, dotted lines to indicate whether it was a direct or indirect relationship, etc. You can even use cross lines if there was points of confusion or tension. Now, I'm going to give you 5 minutes to do that. So it's 1 p.m. my time right now. So I'll call you in within 5 minutes, or at the end of 5 minutes, and we'll just discuss some of those key health response actors. So please go ahead and take that time.
Ms. Lu, can I just suggest you go first to task A, please, so we can understand part A and then go to task B. Thank you.
Yes, of course. You can choose a disaster. I've just put some examples there. It could be a disaster response that you've personally been involved in. And then what I'd like you to do is I want you to list down who was involved in the disaster and what they did for health, what they did in the health response, okay? Because there's many levels of health response actors, all the way from the DESA, the village level, up to the national level. And then quickly make your own or create your own, what I call actor map. What kind of direct relationship did they have with one another? And what sort of reporting hierarchy was in place? So it's just a visual exercise to see how many health response players were involved. And then we'll look at how that got coordinated. Okay, I wonder how you are all traveling with that exercise, because here's the key point. After you've figured out who responded, what relationships in your capacity, in your institution, do you consider to be the most important? And where could your presence have strengthened the response in either the tropical cyclone or the earthquake or the volcano, or indeed a global pandemic? Because whatever relationship you think is the most important, those are the people that you want to be contingency planning with right now. If they are the first boots on the ground, or they are the ones to set up a health emergency operations centre, they are the folk you want to be establishing a relationship with right now. So I wonder if the centre of gravity lay with the Ministry of Health in the health response, or whether it was with BNPB or BPBD. I wonder whether a HEOC, a Health Emergencies Operations Centre, was activated, and whether you were a part of that. I wonder whether or not the health cluster was involved. So the health cluster is chaired by World Health Organization in support of the Ministry of Health, and they bring in all emergency medical teams under the cluster umbrella, and they collate data, and they share information out into the wider system. I wonder if you've had experience with the health cluster before. And please don't be shy of contributing on whether or not you have had those experiences. One thing we do know for sure is that there will always be a hierarchy, a system of hierarchy in place. And that BNPB have rules of engagement. The Department of Defence have rules of engagement. Ministry of Health have their own coordination platform and internal structures. And sometimes, or in fact often, it can become quite confusing on who's in charge. Who do I need to, or my organisation, who do I need to approach in order to find out what is going on? Where do we fit so that we can act? Now, it does mean developing an appreciation of an incident command system. This is an example, it's not the Indonesian example, but there is an incident command system which is globally recognized and which military, urban search and rescue, police, paramedics, they all understand this incident command system. And if you're not sure how that system works, it can be very difficult to penetrate, and you won't get the information you need to act. So I think it's a very good use of your time to find out what are the command and control structures in your area of operations, what command and control structures are in place, and what would happen at the onset of a disaster, what coordination platform would be activated. So if we look at this example, which is more of an incident management system, these are generic terms, a health incident management team. This can correlate to your mass casualty incident protocols, be that a train accident or a plane accident, etc. Incident command systems have an incident controller. Traditionally, that is a TNI, a defense officer, is the incident controller. And the center of gravity sits there with the incident controller and his or her emergency management team. And they will be the ones who will initially assess the damage and the need. And they will be calling, you know, to the National Emergency Operations Room, it's bad, it's big, you know, send the 101 Airborne Division, send in the International Red Cross. They will be the ones to assess what is going to be required. Now, all health command posts have a planning and a logistics side of the house, and they have operations as well. Now, the operations is where you will have who's looking after the public health, who's looking after the clinical, you know, who's going to be responsible for the medical response, etc. And on a very big disaster like an earthquake, you will have, you know, health commanders in various locations that have been affected. So let me pause there and see if there's any, you know, any questions on this notion of an actor map, which again I use all the time because it helps me brief incoming personnel. If I have a visual actor map on my wall in my operations center, I can say, here is where you fit in. This is the line of command. And this is the person responsible for clearing any actions that we undertake.
Ms. Lu, if I can add opinion to this, can I please?
Please, yes.
Yeah, thank you very much. I think it's not very, what I call it, this draft that you drew is similar, is almost similar to actually to what the reality in Indonesia. However, what I can say here, that BNPB or central government in this case should work together with governor as well as with mayor or region, bupati, wali kota. So because we have different decentralization system, so the governor or the mayor should involve district level of how in English, health office in district or in provincial level. So I can see here you missed something here actually, but and then the most involved in this case actually, because the community affected by the disaster, so district level should work very hard, and they are first responder to the community to provide health as well as the puskesmas and hospitals. You say clinics actually is good ones. And then TNI, usually TNI also work together with the community. So directly actually after BNPB request the help, the assistance from the headquarters of military or police. So because military and police department have like direct commands, it can be direct commands to district TNA quota. So those TNI and police also work very closely with community, but they always ask the permission from BPA before, like you said earlier, incident commander system, because we have IC actually in our system to provide a service to the community. That's maybe my addition to your chart. Thank you.
Oh, thank you, Pak Burton. It's so important that we get your knowledge on the system representing BNPB. Of course, this actor map is a fiction. It's just a scenario. But what I appreciate very much is you're pulling out the very important collaborations and rules of engagement between the various operators. And of course, that will change with, well, the system is in place, but no disaster is ever actually always the same. And so it will be nuanced depending on how people react. But thank you very much, Pak, for that. If there's any other comment. Okay. There you go. That's one little component of emergency preparedness, is making sure your actor map is up to date and quite correct. Okay, I want to build a timeline with you, if I may, on a disaster response. And the general consensus is that all disasters are local. They are local in perspective. So the local community will be on its own to deal with this event in the first hours after the disaster. They are going to be retrieving their family members, you know, collecting their possessions, doing a head count in their neighborhood. Local religious institutions also coexist within the community. They have immediate access. They can provide basic life-saving assistance. Often we find too that the local synagogue or mosque or temple or church is the last building standing in a tropical cyclone, for example, because they're built very well and they become the go-to place for the local community. Okay. My apologies. Then you have your local NGOs. They're often the first on the ground. They have immediate access. They can provide material, psychosocial support. But like the government, the local government, they're also probably likely to be affected themselves. When we talk about local government, they have a primary responsibility in disaster response, and that is the restoration of law and order. Okay, they got to put up the cordon and they have to stop the looting. Stand by. And then as Berton mentioned, we have the National Disaster Management Authority. So this is the lead agency, coordinating agency in disaster response. It's responsible for preparing for, directing and managing all aspects of the response at a national, provincial and district level. And you will also see your National Defence Force. So TNI see disaster response as their mandate. They have they're the primary respondents and they provide a direct response. Okay, so the key functions for TNI include leading on search and rescue. They set up the incident command system. They're very big on logistics. They can deploy medical teams and equipment. They can set up their facilities, tented facilities on site. And they're also members of the Indonesian Rapid Response and Assistance Team. In fact, they've formed their own rapid reaction force. So these are guys and gals that can pick up sticks very quickly within hours of the disaster and have boots on ground. Now, the scale might be so big as to require international search and rescue. So other countries can come and assist. Excuse me. And what their role is, they come in, they clear the rubble, they shore up buildings, they save lives, they retrieve the dead, and they establish the main supply route. In other words, their role is to get the access open for everybody else. Now, at the same time, the National Society of the Red Cross, in this case PMI, would be coinciding with the humanitarian response. So PMI establish immediate registration processes for assistance, and they provide the materials to meet those basic survival needs. Now, also there would be joint initial damage and needs assessments, as Berton spoke about, and NGOs and or the defence would be starting to set up temporary accommodations. Now, I've put up these three symbols here of the National Society: the cross, the crescent, and the diamond. It's a neutral sign. They are all symbols of protection, and there are quite significant differences in the Red Cross societies around the world. So if I look at, for example, the Federation of the Red Cross, it's in Geneva. It's on the left-hand side. They are operational in non-combat zones. So what I'd like you to do now is find out what the International Committee of the Red Cross, what do they do? What is their mandate? So just grab your iPhone, your iPad, and Google ICRC. ICRC. Is anyone able to tell me the difference between ICRC and IFRC? International Committee of Red Cross. They have a protection mandate under the international humanitarian law to uphold the Geneva Conventions. Okay, so they've been around for a very long time and they are operational in war zones. The IFRC, International Federation, which is a coordinating body for all the national societies, some 186 national societies around the world, they're operational in natural disasters, non-conflict zones. And so very big national societies like PMI, or Australian Red Cross, can provide support and assistance either bilaterally or through the International Federation of the Red Cross. And those guys are the first on the scene in major disasters all over the world. So, interesting to know if you are in or see the Red Cross that there are very different mandates. Although for national societies, they are an auxiliary arm to government. They are mandated to support government in time of a disaster. Now, the last actor that I wanted to touch on is one that is often the first on the ground, indeed, and that's Ministry of Health at the subnational level. Ministry of Health in Indonesia have 9 crises centres around the country, and they're coordinated nationally in Jakarta. So this is where the 9 crisis centres would have their own health emergency operations centre, which they would stand up, activate in the time of a disaster. And World Health Organization is working with Ministry of Health to establish joint warehouses in these 9 centres around the country. And they can rapidly supply medical kits, testing kits, hygiene supplies, generators, etc. So that's Preparedness 101. So it's a complicated scene. There's lots of different actors, different mandates, different capacities. But as I said, Indonesia does have a very strong and robust disaster management framework, and they can respond. You can respond using your internal coordination structures. But it also has weak infrastructure, and that does create some vulnerabilities in disaster response. And that's where the cluster system comes into force. So, sorry. International systems can be activated, as I said, in times of a large disaster, and the UN partners with the government of Indonesia to ensure that local governments and communities have access to knowledge, to skills, to minimise disaster response and improve their recovery. And this mechanism is called the cluster system, which you may be aware of. The cluster system is where agencies agree to work together to achieve a common aim. So we call them the big hitters. These are the big UN agencies who have a lead globally on shelter, non-food items, nutrition, health, protection, education. They have this big cheese, if you like, and they have sliced up the big cheese, and there are global coordinators who have been appointed as almost the providers of last resort. Their job is to strengthen preparedness. Their job is to support government, if requested, to strengthen the preparedness and the technical capacity to respond. So at a country level, at Indonesia level, the cluster leads for, well, as I look at this circle, a health response would have an interaction with, well, they'd certainly have an interaction with food, because if you've got chronic or severe malnutrition, then this is going to require an intervention, a health intervention in therapeutic or supplementary food. It would have a direct relationship with logistics, with water, sanitation and hygiene. These are core technical sectors which intersect with health. Because if you change one component in one of those sectors, it has a profound impact in the health of the population, which we'll look at shortly. So that's called the cluster system. It's the UN's system for improving the quality and the predictability of a response. And you can see World Food Programme, UNICEF, the High Commission for Refugees, International Federation of Red Cross, they are all there in these core sectors. Now, the cluster became a useful mechanism for sharing information as well, to streamline the delivery. So for every sector, whether that be health, shelter, water and sanitation, etc., a cluster of organisations with similar interests and expertise, they would all come together around the same table. And with the government leading, cluster coordinators would begin to address needs with their partner organisations. Now, this is also part of your preparedness as well as response planning. And what they would do is start to develop what they call a gap analysis. So they list all the tasks required to meet the needs. They list the partners that they are planning with, and this would show or begin to show some of the potential gaps and overlaps in your particular sector. So that if we looked at the core technical sectors once again, food, water, sanitation, security, shelter, logistics, and health, and we particularly took the food sector, these are all the tasks that need to be undertaken. You know, what is going to be the distribution, what kind of ration, what kind of nutritional uptake, you know, has it cleared the customs, can we distribute it? These are all the tasks. Then this potentially shows what areas are under-resourced. It's called a gap identification analysis. Now, this list can be amended as more and more teams arrive or more and more tasks are identified, a gap ID matrix. So if we were to talk about gaps and overlaps, when you are looking here, what do you notice about this matrix? Well, the first thing that I see is that absolutely nobody is addressing this task. So there's a big gap. The second thing you might have noticed is that all but one agency is on this task. So that's a huge overlap and we're probably duplicating. And the third thing as a cluster coordinator that I would see is that, you know, agency number 8 seems to have a lot of work. And I have to check when they say, yes, we can you actually do what you say you do? So that exercise, again, of gap analysis, which is a little, you know, similar to quick and easy formula like an actor map, is a core component of contingency planning for disasters. So you can do this before the disaster, and you can also do it at the onset of a disaster to see potential gaps and to see what areas are under-resourced. So you can start moving now to address those areas which are under-resourced. Okay, so if we talk about contingency planning for disasters, and for the purpose of this session, a contingency is a situation that is likely to occur but may not. And we use the contingency planning tool as a management tool to help anticipate and solve problems. Now, it's extremely important but can be done later, whereas the response is extremely urgent but must be done now. The thing is, we try and do the easy things while they are still easy. So if you haven't started your contingency planning process, it's too late to do that when the ash is falling. It's even if the plan is not accurate, the planning process is equally, if not more, important. That is where you start to establish your relationships, your network, so that you can pick up and call that person or that agency. You know what materials, what equipment that they have to be able to support. All contingency plans, I might add, and that's a resource that you're more than happy to download and access for free. They generally include a trigger point. Now, a trigger point is a threshold that once it's crossed, it triggers a certain set of actions, and it's often linked to your early warning system. So Indonesia has a very comprehensive tsunami early warning system, for example. And if a certain magnitude is reached, that's the trigger point. People go into the response side of the house. So contingency planning, having that in your back pocket, enables you to do something and to do it quickly. So I cannot underestimate this enough. You have to build your scenarios applicable to where you live, to what you would likely be responding to. And that means you've got to be building with your partners. So you're always asking remember back in the early part of the presentation, which relationships do you think are most important? These are the folk that you're grabbing and saying, what if this happens? What then? Who will do what? Okay, get together and do your gap analysis. Figure out how you can strengthen the response. And it also gives you a benchmark to say, this is not something that we are able to do unless we have a X, Y, and Z. So it can be a justification, if you like. Okay. So I know that Ministry of Health and World Health Organization are developing contingency planning exercises. They are also developing simulations to practice your contingency plan scenario. And that's for disasters and potential health outbreaks. And they're doing that at a decentralized level. So I wonder if you've heard about this initiative. It's an excellent initiative. Ministry of Health, WHO, developing contingency plans and simulation exercises at a decentralized level. If you have, and you have tapped into that, that's an excellent start to emergency preparedness. So let's find out where you might be in terms of contingency planning. If there's no contingency planning is taking place, but there are interagency meetings. Okay, so you are tapping into some interagency coordination on disasters. Or there is contingency planning is already taking place, but not in the context of an interagency meeting. So you're just doing it, you know, in your clinic, in your hospital, in your institution, but as yet you have not included other people into that contingency planning process. Well, if that's the case, go out and build the relationship, please, and include your partner. If there is interagency connection, try to encourage that contingency planning is part of the agenda, so that it's the process of building and updating your inventory. If there's no contingency planning taking place, and there are no interagency meetings taking place, then beginning this exercise of gap analysis, etc., is a great way to stimulate people coming together. If you're doing all of this, congratulations. Okay, if you've tapped into your district or your sub-level of government in contingency planning, that's absolutely brilliant. You're in a better place as a result of that than not having done that. And then it's now about, well, how can we strengthen my institution? How can we strengthen that process? So I'm going to do a quick exercise with you now that I've stopped coughing. And it's a fun exercise, okay? That's nothing to be taken too seriously. You're not being tested or graded on this, but it's to see how much collective contingency planning experience we have in this room. I'm going to take you through an evolving scenario, and then I'm going to award you some penalties or some bonuses, depending on whether or not your contingency plan included the necessary aspects that I have in my scenario. Now, there are 8 scenarios, so I want you to just, on a sheet of paper, in a column 1 through to 8, okay? And you'll have to put your time against each of those scenarios. All right, and we'll calculate how quickly you were able to respond. All right, here we go. Here's Indonesia. Okay. And you, colleagues, have been asked to represent your health organization at an interagency meeting in Bandung. Okay, and it includes government agencies, Defense Force, UN, NGOs, and the purpose is to conduct an emergency response planning exercise for the possibility of an earthquake in Western Java. Okay, that is the scenario. And guess what? You were the one chosen to represent your agency. Now, on a single sheet of paper, I want you to list as many elements as you can, specific practical examples of how you have prepared for this meeting. Okay, so all the elements that you would consider to be essential to an emergency response contingency plan. If I was to pick up the book or the guidance and open it up, what would I see in there as critical, okay, for this scenario? Now, you don't have to write the plan. You just have to list the essential elements that would be in that plan, okay? Is it clear, folks? Excellent. Yeah. Great. You have 5 minutes, and yes, your time starts now, and the clock will tick, and then we'll see how well you are at contingency planning. Please cheat. Go on and look in your organization's contingency plan, see what Ministry of Health do, the UN, get it all down there. Here I go. Unmute, start video, and 5, 4, 3, 2, 1. 30 seconds left. Okay, make sure you got it down. If it's not on your list of paper, it doesn't count. And That's it. Time's up. Let's have a look, ladies and gentlemen. Now, the situation is this. Something's coming up on our screen, on our radar. It's an early warning signal. That's good. We've received news of a major volcanic eruption on the previously dormant Mount Pangrango, and it's affecting the city of Sukabumi. So you've actually contingency planned for the wrong contingency. But still, there are certain elements that are, you know, non-negotiable in all. So have you included, there you go, members of the crisis management team will have to gather for an emergency meeting to plan for the immediate response. Has your plan included a crisis management team or a similar body? So I want you to think about your hospital, I want you to think about your unit, your department. Do you have a CMT in place? If you do, fantastic. It's only going to take 1 hour. If you don't have a CMT, disaster management team or crisis management team, it's going to take you 2 hours to encourage people, you know, to come and gather, and a big disaster, we have to do something. So there's your first score. The second one, media are broadcasting news of the event around the country. Offers of assistance are coming in from other cities, and they want to know what are the immediate needs. So have you included planning estimates? Okay, assumptions about what the projected health needs would be in the event of a volcano, an earthquake of 7.9 magnitude. These are contingencies which you specifically plan for because they are applicable to where you live. All right, and also what available supplies are. So if you have included those planning estimates, well done. You can pick up the phone and immediately say to the chain of command, we will need 10,000 litres of fresh water. We will need medical supplies, family kits for 10,000 people, whatever. Oh, if you don't, it'll take 2 hours if you didn't include that. But you do get an extra credit if you wrote down specifically that you've identified your own emergency stockpile, okay, somewhere in the basement where you keep your essential items so that you can pick up your bag and go on a mobile clinic or do what you need to do. With me so far?
Yes.
That's number 2. Let's have a look how you went on the next one. Volcano erupting, affecting Sukabumi. Okay, responding to the emergency will require specialised expertise, search and rescue, medical and emergency services, etc., to immediately assemble at a designated command post. Right, I spoke about the incident commander. They set up a command post. Now, we're not military, but we do need to have a designated assembly point. Okay, if the ground is moving under our feet, or if we need to deploy, there should be a designated assembly point where people need to go. Now, if you have planned with the relevant health authorities, you will know where those designated assembly points are. Great, it will only take you 1 hour. If you haven't done that, if you don't know where you're going, it's going to take you 2 hours. Okay, number 4, health responders and relief supplies are arriving at the designated assembly point, which is 15 kilometres from your area of operations. Ooh, that's a long way to walk. Have you planned for the logistics and transport for emergency responders and equipment to and from the incident site? If yes, 1 hour. If no, 2 hours. Now, the volcano is affecting surrounding communities. Many sectors are responding simultaneously. Shelter, comms, food, search and rescue. Has your plan detailed guidelines on the mandated task or the division of labour between core response agencies? Are you both distributing hygiene kits when only one agency needs to do that? Are you both chlorinating water, or is one agency to do that? Have you divided the tasks and the division of labour? If yes, only takes an hour. If no, 2 hours. Okay, offers of assistance are pouring in from hundreds of local and national NGOs. They want to know where and how they can best help. In your contingency plan, have you planned for the coordination of civil society responders, people who genuinely want to help, okay, in your emergency response plan? Because you will get hundreds of people who will say that they've been a nurse, they're a visiting doctor, they want to help. If you have planned for that, it'll take 1 hour to sort that out. If you haven't, it's going to take you 2 hours to talk to everybody to say, no, look, thank you, but no, thank you. So it's an extra credit if your plan included an assembly point for the reception of new responders into the overall health response. In other words, don't have them in your resus bay. You need to put them somewhere out of the way of the immediate response without causing offence. Now, numerous health emergency responders are arriving. They will need to be able to communicate with one another. Have you included a communications plan? That's equipment like satellite phones, VHF, HF radios, mobile phone chargers, etc. If you have, excellent, well done. It only takes you 1 hour. If you haven't done that, it's going to take about 2 hours. And there's an extra credit if you specifically included a backup means of communication. That could be a generator, a satellite phone, spare mobile phones with cards, etc. You get to take 1 hour off. And finally, this is an interesting one. You receive an offer of assistance to fly relief items to your facility. But in exchange for that, you need to deploy an emergency medical team to the disaster site. And you'll be using military helicopters. So in your contingency plan, do you specifically address the policy level issues of dealing with political and military requests? If you know the chain of command and who has the final decision, and it's in the plan, great, takes 1 hour. If you don't, well, it's going to take 2 hours to figure that out. So folks, I want you to total up your time. And of course, this is by no means an exhaustive list. And if you were less than 6 hours on the clock, then you are, in my mind, a team of crack planners. Congratulations, well done. If you were around 6 to 12 hours, well, okay, that's okay. You were thinking about contingency plans in a positive way. And if you were sort of like 12 hours to 24 hours, then you've probably been affected by the earthquake and you've had to hand over to your second in command. Okay. Now, this is all, was there any major elements in there that that you think is important, but that you did not see? Now is the time. What else is really important in a contingency plan? sometimes we call it an alert tree. It's a duty officer that holds the duty phone, and they have a responsibility of contacting people in the event that a certain threshold is triggered. That's always a good part. Okay, so I'm going to move on to a little bit of the response phase now. It's the SPHERE project, because this is all about doing the right thing in the right way. Now, SPHERE has been going around for 30 years now. It's what most responders use when they are responding to a disaster. It's a universal approach to minimum standards, and it also is used to quantify how bad the problem is. All right, and as a benchmark for us to say that there is not enough water, there's not enough showers, there are not enough toilets, this evacuation centre is not okay. Okay, it's not perfect, but it has revolutionised how assistance is delivered, because despite all the international laws and principles, some countries have a very different interpretation of what a dignified life is, and indeed what it means to survive with dignity, regardless of whether they're flood affected in Asia or an earthquake victim in South America or a genocide survivor in Africa. So there was a very strong call for accreditation to ensure that people received an acceptable level of service and care. And indeed, what we needed was a universal minimum standards that could address this problem, okay, the quantification problem. How bad is it? What benchmark could we use to describe this situation quickly, clearly, and as correctly as possible? We needed to know, when assessing this child, what do we report? Or indeed, this child. Is this water, for example, potable? Or this? Can she drink it? Can she cook with it or bathe in it? How do we know if this house is safe to inhabit? Or if this is sufficient shelter for a family of 5 or 7 or 10 people? Indeed, when describing a community affected by a disaster, how would you describe the overall health situation in this camp or in this camp? And what does it mean to have a right to life with dignity in practice? So we certainly know what humiliation looks like, begging for food or fighting for it. But how do we measure if we've provided a right under the international human rights laws? And it's where the SPHERE project was born. So I'm going to show you now this project. Okay, it's been probably one of the most fundamental changes in the 21st century. And we'll look at its technical sectors now.
Those affected by disaster or conflict have both a right to life with dignity and a right to assistance. All possible steps should be taken to alleviate their suffering. The SPHERE minimum standards are your tool to providing quality assistance during humanitarian response. So what's it all about? Its key message is simple but important. Everybody on this planet has a right to life with dignity, no matter their situation or circumstances. So how do we achieve this mission? The SPHERE Handbook sets out 4 minimum standards in key life-saving areas. They're there to ensure the survival and dignity of those involved in crises. First, water supply, sanitation and hygiene promotion. WASH. Water is critical for survival, whether it's providing enough water for people to drink and wash with, making sure waste is disposed of correctly, or promoting good hygiene practices. water has a key role in any emergency. Next is food security and nutrition. 2,100. That's the number of calories somebody needs a day to survive with dignity. But that's not all. The nutritional value of the food is imperative too. By ensuring people have access to food, we give them the best chance of survival. Third, it's shelter, settlement, and non-food items. Everyone has a right to adequate housing. The minimum standard reminds us that shelter and non-food items like clothing, blankets, and bedding are necessary. They provide security, personal safety, and protection from the climate, while promoting resistance to ill health and disease. And finally, health action. Emergencies lead to a lot of people living close together in very small spaces. Illness is often inevitable. Diseases such as typhoid and malaria spread easily in crowded areas. It's vital to respond quickly to diseases and act in the present to prevent future life-threatening issues. The use of the SPEAR minimum standards promotes collaboration. By working together, we can all help to give people in need the best support possible in the 4 key life-saving areas. If we achieve this, we ensure the right to life with dignity. Visit here to learn more.
Okay, folks, so that was the SPEAR project. It's what most of us use as a guidance for how we are going to craft our response to a disaster. The idea that you have 4 core technical sectors: water, sanitation, and hygiene promotion. You have food and nutrition, you have shelter and non-food items, and you have a health response. And the minimum standards there are the qualitative nature. They serve as the benchmark, as I said, to say, sorry, but this is just not okay. We consider it a dignified life that every family have a toilet, but in a crowded post-disaster, no more than 20 people per toilet. Okay, that is the minimum standard for a dignified life. We don't expect starving people to eat just anything, right? They have to have a well-balanced 2100 kilocalorie diet. Then the key actions are all the practical inputs to help you meet those standards. And then the key indicators are those signals and clues that give us the progress, whether or not that standard has been achieved. And the most excellent part is the guidance note, because if the disaster is happening in an urban setting or in a cold climate or a rural setting, you know, these are the, if you like, they tackle the practical difficulties of how to deliver the SPHERE standards. So if these are the kind of resources that you will have online, the health cluster guidelines, the minimum standards in health actions, they help you with your operational planning, okay, and implementing and then reporting on your response, so that if your government says, okay, you and your team or organization, you are going to have to establish a temporary outpatient department, you know, post disaster, then you will know how to do that with the SPHERE guidelines and with the WHO emergency medical team guidelines. You can, you know, consider access, how much water you need, key sanitation issues, land gradients, drainage. What do you do with excreta waste, you know, hard waste management, vector control, etc. Okay, because we are focusing on the earthquake response, I'm going to show you some initial footage of the presence of one agency, always there in disasters and emergency, the International Federation of the Red Cross. And as you're looking at this, I would like you to consider, for example, you know, the implications of these images on a medical deployment at home in Indonesia. And Dr. Terry, if the volume is not coming in correctly, you let me know.
Video.
We can see the video. Okay.
Okay, thank you.
Oh, I think you just paused the video, Lou. So.
I'm sorry, I did too. Hang on.
Our priorities are really geared on the life-saving. People will die if they don't get medical assistance. They will die if they don't get drinking water. Everything needs to be done at once, but we can't.
They're coming by the truckload with all types of fractures, bones broken, skulls broken, jaws, and it's a matter of just trying to step through these.
Excusez, s'il vous plaît, excusez, s'il vous plaît. We have the volunteer, but we have not the materials that we need. The media pressure is heavy. They're all asking the same question. Why is it so slow to distribute? Can you give me a figure of the number of trucks we need for the next 2 days just to bring this? 50. You go in, people get pushy, it gets too problematic, forfeit the goods, and just retreat.
It's not he can't distribute because he's not asking for enough, or I can't deliver. That's what we can get for the pipeline at the moment, given all those other constraints.
This is my first disaster operation. No one could have explained this to me. You really have to see it to believe it and to understand it.
The challenge we have had is that there are just too many surgeons, not enough nurses, not enough tents, not enough beds. Nobody wants to be in buildings, understandably.
The biggest logistics operation the Federation's ever run. This is probably the most challenging for me, technically and physically difficult to get the job done.
Okay, so Haiti. Haiti was a very big learning experience for all of us. Indeed, you could say it wasn't the earthquake so much that caused the disaster in Haiti, but 100 years of bad governance, poor building regulations, endemic poverty, environmental degradation, and then the earthquake. Okay, communities were just too vulnerable to withstand that impact. It collapsed the most densely populated area of the country. It destroyed the economic and administrative centre. And it seriously crippled what was a very meagre health system anyway. Now that video threw up a number of challenges, not the least of the whole question of a logistics pipeline and the demand and supply. Too many surgeons, not enough nurses, which was a very profound, observation at that point. It generated a massive medical response. There were people turning up, performing amputations who were not even surgeons. So credentialed teams were reporting about 1% of their caseload as amputees. Uncredentialed teams were reporting up to 64% of guillotine type fractures. And I'm not a doctor, but I can see that that is a very poor amputation. So too many amputations done too quickly, no pain management. It caused a very big reform, and that reform happened at the World Health Organization, and it's called the EMT Initiative, Emergency Medical Teams. These is a name that describes certain capacities of medical teams who can respond to very big disasters. So the first one there you can see is a type 1 mobile, what I sometimes call truck and chuck medicine. So open up the back of the truck and start doing initial treatments. Or a fixed, which is normally, you know, a health clinic, single nurse staffed health clinic. You then have a type 2 facility, which is a tented field hospital when everything has been demolished. And that's what the Australian team has got. And then you have a type 3, which is a referral hospital. Okay, that's the tertiary level. You can't refer on, you're it. There are only 3 type 3 hospitals in the world. Germany has one, Russia and Canada, I believe. So that's what they do, right? They do outpatients. They have the ability to perform surgeries in infield surgery or do very complex surgery. And it allowed a government to know who they were accepting and who they did not need. And it's linked to your referral pathways or escalating levels of care. So we know that, for example, you normally can refer from one level to the next and then refer back down the level as patients improve. But in a sudden onset disaster, a percentage of hospitals and clinics will be knocked out. And so when the government says, yes, okay, we do need our emergency medical teams to go nationally or internationally, they can get a best guess on where and what capacity they need. Every country right now is working to develop their national capacity to respond, and that's normally type 1 and type 2. And some international communities can also respond with a type 3 facility or a type 2. Now, the thing with that is that the research has come out after the 5 last big disasters. And I want to take a look at this conceptual model of disaster management and time and the burden on disease. Now, this was come out post-Haiti as well. We have 3 distinct waves. The first wave, number 1 that you can see there, is the peak of trauma deaths. Okay, straight after, between 72 hours after the assault of a natural disaster. And that's chest, head, abdominal, etc. Very big demand on hospital resources due to high casualties, and the normal activity stops. So your elective surgery, etc. stops. Now, if this is not likely to improve unless you get an increased local capacity to manage trauma, or you have an extremely fast response by national or regional emergency medical team facilities. Then what they found is after that 1 to 3 day period, at about day 5 to 7, you get phase 2.
I'm sorry.
And this is where your normal
10 minutes more. Sorry.
Thanks very much, Doc. Skull fractures, still alive, still need to be nimble. Pardon me, let me go back. And then you got the 3rd wave. Now, after about day 10 of a disaster, there's no more trauma to treat. Either you've treated or they have died, essentially. And so what was happening was that countries were still sending in their trauma teams, their trauma hospitals, their trauma surgeons, and it was too late. So under the WHO guidelines for EMT, it's inappropriate to just come for surgery. Okay, you must be able to manage the infectious disease outbreak, and that's the 3rd wave. Infectious and chronic disease spike. Type 2 diabetes, already high in many countries, becomes acute after day 7. People have lost their medications. They're not geared up to survive without insulin. So each EMT must be able to manage either wave 3, infectious disease, and refer surgical cases, or they have to handle both. And then wave 4 corresponds to your normal case management, which, well, it's been delayed, but it has not disappeared. So there you go. Pardon me. That is the moral of the story. Okay, transition to non-trauma after an earthquake happens very quickly, happens in days, and government and teams need to be ready for that. Now again, the way in which disaster response is organised in ASEAN is very different to the rest of the world. So we have the United Nations resolutions, relief coordinators, OCHA, etc. In ASEAN, you have the AHA Centre, the Agency for Humanitarian Affairs. It sits in Jakarta, and it's responsible for the ASEAN Agreement on Disaster Management and Emergency Response. So there's a lot of very good mechanisms in place in our neighbourhood. They put out these dashboards every week. In a disaster, they will put them out every day, every hour. And they have emergency rapid assessment teams, which can help the, the rapid reaction forces of TNI, and they assist the National Disaster Management Authority. OCHA is the UN body. It can do exactly the same. So this is Nepal's earthquake. This is the snapshot of military assets that was offered and accepted. This is a snapshot of the emergency medical teams that were offered and accepted. And because of that system in place, they knew where they could send the teams to augment or not only augment, but be the only clinic and hospital in town. And these are the search and rescue teams that were sent. Now, the initial response after an earthquake in your country is that you will have to do rudimentary mapping with the military. And they will assign different sectors. These are geographical sectors, not life-saving sectors. And then each team, once they had cleared that area, shored up the building, cleared the road, etc., they cross it off. And eventually, the map looks like this, which means that we can go in and safely carry out our humanitarian work. Now, of course, by the time you arrive on the scene, it looks like this. People are desperate to get out. Others are desperate to get in. And if you can imagine this in the time of a pandemic, the next one being just around the corner, then we've got a huge task ahead of us. And we're still trying to work this out. So if I talk about responding under the cover of COVID, well, I think you probably have more experience of it now than what I ever would have. Let me see where my notes are. Sorry. Yeah, the coronavirus, it's obviously continuing around the world. It's affecting countries in different ways. And as our opening speakers mentioned, government strategies for COVID and dealing with that change from one country to the next. So in Australia, for example, strict lockdown, social distancing and staying at home. that was the strategy. In north of, in our neighbouring countries, no, that's not possible. Countries need their economies to keep running. People are dependent on those economies for survival. And so trying to combat the spread of infection of COVID has been almost impossible to work with. Countries now, look at the US, they are waiting for the rollout of vaccines as a response to COVID. If I was to talk about any solutions to a pandemic, I guess I would be talking about in the sense of post-disaster and having your hospital or evacuation treatment centre set up. And this is whether it's Ebola, Zika, the new Nipah virus just around the corner of COVID. Your facility needs to have green zones and red zones. And the red zone is where you have the infectious disease caseload, where your donning and doffing of PPE has to be absolutely, a top class protocol. And that's just an example of a type 2 facility that would be working in a COVID post an earthquake response. So the half a dozen, and I finish on this, the half a dozen messages on COVID, and this is what we've learned. We need clear public messaging in as many dialects as we can. If people are walking into our resus bays or our triage areas, we've got it. Public messaging all around the tent so that folk can understand what they're looking for. The pre-positioning of supplies and medical equipment is absolutely key. Yes, you have to rotate your pharmaceuticals, but generally you want your cache ready to go. Setting up triage and separate isolation facilities for evacuees with symptoms of COVID is a must. Providing utensils and basic equipment so people are not sharing. That includes mattresses, blankets, whatever. There's got to be wash, wash, wash. Water, sanitation, hygiene. And prioritizing PCR tests for emergency responders, because you are our front liners. Okay, you are on the front line. You have been dealing with this day in, day out for nearly 1 year, and your health and continuing well-being is an absolute priority. So I cannot begin to tell you how much we keep you in our prayers, that you keep safe and keep well during this period of COVID. I've taken a lot of time and I've coughed a lot, and I really do apologise for that. But I want to thank you for your sustained interest and staying with the presentation for this long. And I do acknowledge that I didn't get round to any questions, so my interactive lecture was probably less interactive than most. But I think on that note, I will finish off with just this slide on resources, again, which you can access. They're very good information booklets. And that extranet site of World Health Organization, along with your own Ministry of Health guidelines, should give you some excellent starting points of how to, you can't be everything for everyone, but you do have a critical role to play in the disaster response. Okay, so on that note, thank you, Dr. Andre, for inviting me, and I think I shall hand over now to yourself or Dr. Terry.
Okay, thank you. The discussion will be after the next speaker. We really enjoy your talk, and now we move to other speaker, Mr. Berton. He is the head of educational program in Indonesian National Board of Disaster. He did a master degree in Australia and PhD in New Zealand, and he will talk about our preparedness during COVID in Indonesia. Time is yours, Mr. Berton.
Thank you, Dr. Andre, and thank you, Ms. Lo. It's been grateful for me to listen to what you just discussed now. and a lot of things that you taught actually, and then I learned a lot from you. Thank you very much, being wonderful. And thank you, Pak Andri and the team, Ibu Selvi, and Pak Sutrisno, that invited me to this important webinar. And then I'd like to share my. Can I have access, please? If yes, thank you. If I can share my presentations. Can you see my presentation?
Sure. Clearly.
Yes. Okay. I think I like to highlight firstly before I start, because my topic would be very it's not directly to COVID-19, but I touch firstly about the natural hazard in Indonesia. Hopefully, the previous talks from 2 days webinar earlier didn't I'll talk much about I'm presenting right now. But if it is my aid to some of your knowledge. I think it is important for us to understand the situation of Indonesia related to hazard or to disaster, because we live in this area. Even maybe most of you doctors as well as medical students, we need to understand this so we can prepare ourselves in terms of health sector or medical measures. So in the future, we can have good or better understanding as well as preparedness for disaster. So I'm not expert in this kind of topics, but as I listened a lot to workshops or seminars. So experts divide 14 tectonic segments in Indonesia, and those are very active. And you can see here 14 segments, and the most active right now is in this. Can I have my point? What do you call it? In a minute, please. Oh, this is my arrow, my pens. The most active right now is in Maluku. Maluku, as I can draw here, the most active segments right now is Maluku. So, as well as here, last 2 years it was here in Lombok. And then 10 years ago is around here. However, in Sumatra, of Sumatra is still energy still trapped there a lot. I was searching. I was doing my PhD in this area, and I found the literature mentioned that now it was only 30% of energy trapped released in this in Sumatra compound. So probably. Even though it is not very active right now, but the energy is still there. We are expecting some big earthquakes in this area, in these segments, but we need to pray. Smaller earthquakes often occur instead of 1 or 2, but big ones. So. This is the way of tectonic to see Indonesia in terms of tectonic. And you can see that our experts say that natural hazards always return. So in this chart, in this picture, you can see that the egg cave in Aceh. So the cave is about 50 meters above the sea. And then during this tsunami, big wave brought the sediments to the cave. So experts can see the layers of the sediments. So they dated the sediments. So you can see here actually it's about 20 different layers. So it means that quite a lot of tsunamis occur in this compound in Aceh. So you can see here 7,500 years ago to just recently in last 20 years we experienced that that tsunami here. So you can see here it just recently. However, you can see the layers here from 7,500 years ago to 2,800 years ago. But this is just the big layers. In fact, the experts say almost 20 layers, 20 different layers on this cave. So yes, natural hazards return. Here another example of Krakatau erupted during the series of time, even in almost 1,500 years ago until just recently today, 2 years ago. So always again and again, the natural hazard returns. This picture actually mentioned a lot. You cannot see very properly, but if you see here, there are 3 uprooted giant coral reliefs on the land, and those coral reefs brought by the tsunamis in 3,000 years ago, and 1,600 years ago, and 3 years ago. So it could be occur in sometimes next years to come, times to come, but we don't know when exactly. So we gotta prepare for ourselves to those potential events in the future. Once Professor Katili mentioned that the government do not need to build the Palu as a capital. But we didn't listen. The government of Palu, the government of West Central Sulawesi didn't listen to him, because he predicted that in 2000 there would be a big earthquake and tsunami occurred in Palu, but not exactly precisely the time occurred. But 17 years later, it was occur. It occurred a big tsunami, as well as the liquefaction that we could see in media. So Prof. Katili already mentioned, please don't do that. Don't make this Palu become a capital of province. So find out someone else. But yeah, because he knew that earthquakes could occur in the near future. This is the picture of Fort Victoria in Ambon. This as the witness of tsunami in Ambon in 1974, and this is the first recorded earthquake and tsunami in Indonesia by Rompius. Rompius was a biologist, and he was a Dutch, and he came to Ambon and brought his family with him in that time. However, there was a tsunami, an earthquake and tsunami. He recorded detail everything that occurred during that time, even how many people died, how many houses damaged, and unfortunately, his family, his wife and his children swept away by tsunami. He alone lived, and he became a writer to that event. So this is the first recorded event, tsunami and earthquake in Indonesia. by Dutch expert. And again, you can see that a lot of disaster occurred in Ambon during series of time. You can see here. Jakarta also experienced some earthquakes. So, but actually the fault is not next to Jakarta, but it was like from Lebak, for example. Last year we experienced big earthquake in Jakarta because Lebak was shaking. This is the case here in Jakarta. So we need to get prepared actually if one day one or two earthquakes occur in surrounding, Jakarta could be a victim of this earthquake. This is the very new, recently active tectonic zones in Indonesia. You can see here that in Aceh as well, Bengkulu, and then Lampung, West Java, and Bali, as well as apa namanya ini, Lombok, to go to Irian Jaya as well as the Maluku. This is a very active right now. However, the biggest one is always in Maluku and surrounding. Maluku is Laut Banda here, Pulau Seram Island here. So those segments are very active right now. This is the volcano active volcanoes in Indonesia. There are 127 volcano actives, and this is it's almost one fifth of global active volcanoes. So you can see we have a lot of volcano actives. Not mention the dormant as well as latent volcanoes. Once maybe like Sinabung, that it was dormant almost 800 years, but once without any warnings, it erupted. So potentially would be the same with our volcano. Even the dormant ones could be occur in the ones in the future. And those volcano actives lay in 75 districts or cities. So it is important for us to understand our situation. Maybe students, after you finish your medical study, you're gonna be like deployed to one of the districts here. So you can be prepared from now on. What would be happen? What would be a good strategy to prepare yourself or medical team if any happen? Like Ms. Low just mentioned about the emergency plan, contingency plan. It is a good one. It's very practical to do it. So yeah, it's good to know a lot of things actually surrounding our situation right now. So this is the active fault. It was 81 in before 2016, but the expert found it's not a new thing, but they discovered the volcano active become almost 300. In the future, maybe it could be more. It could be more because they characterize, they assess the type of earthquake as well as the segment. So potentially it could be more in the future, like in Sumatra. Maybe it's not only Sumatra fault lines, but there are we call it small fault. So it's like a fish bone. It's a big one's bone, but however there's a tone from the bones. So this is what BNPB just produced last year. There's no safer place actually in Indonesia. We have what you call it risk index, disaster risk index. you can see here, there's no low risk in Indonesia for multi hazards, but all are medium or high. And it's a lot of high risk area in Indonesia. It's like a lips of a beautiful lady, red. So this is to your knowledge that you don't have any safer place. So as an individual as well as health provider in the future, we should understand the situation of Indonesia. This is for West Java. The score of disaster risk index is 150. It is very high actually, because a lot of hazards here. There's some potential for earthquakes, tsunamis, volcanoes, floods, landslides, droughts, bush and forest fire, and abrasions. So a lot of the government and as well as the other stakeholders have been doing. However, the index is still high. So we hope in the future, the government as well as the related body can reduce this disaster risk index. All right, that was my explanation for a potential or reputation of hazard disaster in Indonesia. However, you can see here that we are coping right now with COVID-19 as a communicable disease. So in the future, we can see that the potential disease of tomorrow, it could be a communicable disease. Disease here is not only as a disease, it could be also in the future as a disaster. Like COVID-19, Mr. President mentioned that COVID-19 as a national disaster. So in the last 16 years, there are 4 newly communicable diseases emerge of H1N1 as well as H799 N9, sorry, MERS COVID and then COVID-19. So those new diseases are very likely would happen, this kind of diseases in the future. So it is very frightening actually. The more what you call it in the future could be more intense new communicable disease occur. So we have to prepare for that as well. So this is I can differ the impact of 3 things. The first one is the death because of the natural disasters. In 20 years, the death of natural disasters is almost is over than 1,200,000 people died. It's for 20 years. It's almost similar with conflicts or social conflicts in the global. The death, it could be like 1,000.1 billion, billion, yeah. Okay. However, you can see it's almost is 1 year alone. The COVID-19 already responsible for the death of 1.5 million people over just last 2 days. This number is just last 2 days, and almost 60 million people infected. So you can see here that COVID-19 or maybe potentially like the emergence of other communicable disease will affect us in our lives a lot. As Ms. Lu mentioned earlier, that Indonesia has a very strong law that manage disaster management. So we can see here the law of number 20 year of 2007 mentioned that the government, the central government as well as the local government should responsible for any disaster. So the government is the one who responsible. However, it's not the government alone to be performance of the good job. So it could be, it should involve all sectors as like NGOs, universities, medias, private sectors, as well as NGOs, private sectors, medias. Yeah, those stakeholders should work together before, during, a post-disaster. So the government, BNPB in this case, only to coordinate those sectors to perform their job. Like we discussed earlier about the structure from Ms. Low, that BNPB can work together with TNI and police as well as health department to deploy some resources if any community affected by tsunami, by disasters. So this is the way we work. It's not, maybe not like other countries, but we decentralize disaster as well as other public services. Related to COVID-19, what the government already make as a framework. Firstly, the government make some preventive and promotive measures. Those is more likely to help approach as health promotion through social media as well mass media, because we understand right now that over 90% of the knowledge about COVID-19 came from social media. It means that a lot of people, particularly younger, access to social media. So that's why Satgas, in this case, we call it task force, work very closely with social media to create, to socialize all the message that we have about health promotion. So, and then the other thing is, the most important is how to change the behavior of the community, because it's not easy to change the behavioral that have been attached to the community as well as to individuals. So this is the two most that we created to our job, to our task. But and then in curative measures, as we know that our laboratory for the first time is only 1 or 2 laboratories that can test COVID-19. But fortunately, right now we have 426 laboratories that can test COVID-19. It's a huge jump from, it was only not 6 months, but a lot of things to do during that time. I was one of the persons to push a training of laboratorians to perform how to test the COVID samples. So it was a huge task at that time. From actually two, but one the government, central government mentioned it was in Laboratorium Kesehatan, in Depkes, in Ministry of Health, but in Eijkman is only a very high for referral system. So only one that can in the first time can use, but now is increased quite a lot. The hospital as well is only the first time that can, as a referral system, is only 130 maybe, but now is almost 1,000 hospitals that can provide their services for COVID-19. So this is the huge job of Satgas right now, how to make to change the behavior of the community, as well as to send the message about health promotion. So and then, as a public health emergencies, like I mentioned, have been announced declaimed by the Mr. President as a national disaster. So central government work together with local government and communities and households to make change of behavior through individual and collective disciplines. This is not easy task. As we know, maybe individual can be easily to say something, but as a collective, as a community, it's not easy, and a lot of denials, restrictions, and everything that we can face right now. Our target is above 90%, 80% of the community apply to health protocols. So and then we make the jargon of our for the community to easy to remember, or to quote the message is imun, aman, and dan iman. It means immune system, secure for yourself, as well as your faith. So this is our jargon to enhance public health resilience from COVID-19. There are 8 targets that we need to reach. Firstly is to protect the vulnerable, as well as for health providers, that we know that a lot of doctors and nurses are being victim of COVID-19. So this is the main target of vaccines in days to come. So those people will be the first target to be vaccinated by the government, and then reduce new cases through that we said immune, and aman. So this jargon also can be we understand can reduce the new cases, and of course testing, tracing, and treatment always been there, and health sectors always do their job very good, and vaccination as well. The government now is negotiating with other governments for us to have a lot of vaccines, and our BUMN is government state enterprises also have been developing our own vaccine. Hopefully by the end of next year, the vaccine will be there and can be used for community. As well as we need to provide reagents, PCR and PPA. It was not easy in the beginning, but thanks God right now that those kind of things quite easily to find. A lot of the diplomacy have been performed on around to have our PPA in particular. Massive socialization, as well as behavioral changes and data interoperability is the ones that are among 8 targets of Satgas. And then I like to mention right now about health system response to COVID-19. In prevention measure, we can see the COVID-19 protocol should be there, and then a large scale or social restriction like school closed, some particular selective manufacturing closed, office also closed for some offices, but as well as no mudik. It means no Christmas holiday as well. So these the government already make a lot of policies to reduce, to prevent the COVID-19. And then the government also performed detection measure like to strengthen laboratory as surveillance as well, and response to COVID-19 also. The government always now is building from primary care to secondary referral hospital, now to tertiary referral hospitals. So it's a big job actually, because we know that it's not easy if come to communicable disease. It's not always easy because a lot of high technology being involved in this area. And then, of course, we don't forget this to strengthen community participation and pharmaceutical and medical equipment. This is that I mentioned earlier that now we have 442 laboratories that can do exercise the COVID-19. So it's a huge task, as I say, a huge achievement. I can say that. This is the hospital that it was only 122. Now it's over. It's almost 900, as I mentioned earlier. This slide is old one, but you can see that all over the country now, hospital can be as a referral to COVID-19. And then maybe improving human resource capacities for handling COVID. As I mentioned earlier, I was the one who pushed the government, Minister of Health, as well as the what I call it BPPT, to train the laboratory and surveillance. This is the problem for our health center performance during COVID-19. Working hours is getting smaller, actually, reduce working hours, because this is the policy. Not many hours will be work. Number of visits as well it will decrease. Home visit, it is almost all health centers stated that home visits were not done anymore because they're afraid of the fear of the COVID-19. And then health integrated posyandu is almost 40% declared that the activities of posyandu were declined. So no more activities of posyandu, and even closed. And because of the posyandu also can be a new cluster to the spread of the COVID-19. And then immunization coverage is decline. So this is again the impact of COVID-19 to health system in Indonesia. But 8 areas for health system reform, you can see here: education, of course, education, and strengthening of primary health care. Nowadays, maybe if the spread of COVID-19 become to grassroots, and it could be primary health care can be trained to do their job on COVID-19 instead of going to hospital, because hospital also right now, particularly in big city, there's no more bed for them. BOR is very high. So, and then substantial of pharmaceutical and medical equipment, strengthening health security, and improving communicable disease prevention and control, including immunization, and improving health financing to have more money to allocate it better and use it better. And then the lastly is to strengthen the use of information technology and community empowerment. This is my last slide, maybe. Yes, my last slide. BPS, it is a statistical bureau in Indonesia, made a survey. What they found was 19% of the population say that I never get infected by COVID-19. So this is a huge one. So they never use like mask as well as to keep distant from others. So they believe that they never get infected. So it is very sad actually, because like I said, 80% of our target to change the behavior. But and then the age of them it's mostly in 16 to 30 years old, and there are no difference between them in gender. So almost 60% of them are the same gender, male and female. That's from me. Thank you very much. Over to Dr. Andri. Thank you very much.
Thank you, Mr. Berton. It is very nice presentation and quite clear what we face this pandemic today. Maybe we can start with discussion. I think Lou already answered the question. We have 3 questions, and Lou already answered in chat room. And maybe we have another question, please. Okay, I will comment with Lou that Lou said about Sphere book. Fortunately, we have already in our library the Sphere book, because after I finished my health course in Hawaii, I ordered the librarian to have the very useful book that is Sphere book, and I think we have already in our library. And I also agree with Lou that if there is a disaster inside, I agree that everyone will compete, rise the flag. It means that everybody wants to become a leader, and especially in a government or presidential election, there's a politician there will rise that flag in or during the disaster. What do you think, Mr. Berton? Sometimes it's we have some some problem in the site, because some people they want become a leader, but we believe that BNPB or local is already set up all the need for the beneficiary in the site. Yes.
Yeah, thank you for the question, Dr. Andri. Yes, again, disaster, it could be make another disaster. So in this case, BNPB always adhere to what central government mentions. Like, for example, COVID-19 in the beginning was BNPB as a leader. However, after sometimes, because BNPB as well cannot do about economic impact of COVID-19. So COVID-19 was is a good example actually how all sectors should be involved to solve the problems. So yes, was Satgas BNPB as a leader, However, the president, Mr. President, make a new decision. GNPB only tackle for the pandemic. However, economic or social impact could be another entity. So this is good actually for us to divide the job because a lot of a big job. And then if it's a natural disaster, indeed, I myself train some senior leader from district. Like tomorrow, there would be one training for leader in BPPD as well as district level. Then for them to, Pak Andri, can you mute your phone, please? Your device. Can you mute? Oh, thank you very much. Thank you. Okay. It's not mute, Pak. It's not.
I'm sorry. This interrupted. I think the signal is interrupted.
All right.
There is a question for you, Mr. Berton. The question from Pak Agus Sudrajat. In the context of disaster preparedness, could you please give us some solution for disaster management if war occurred in the remote area of Indonesia where the infrastructure or facility is not as complete as urban area? That question for you.
Yeah, thank you, Pak Agus. Pak Agus, that's a good question. I think, yeah, I think in terms of remote area and occur disaster there, we always, okay, my answer would be like this. Disaster is part of a district task responsible. That is the, so in our government system, this decentralization system, including disaster, become part of it. So if it is occur in one remote area, local government should responsible for that. But again, maybe local government does not have a lot of resources to deploy, and provincial level, provincial government or the surrounding district can help them. That is the system that we made. For example, but Sukabumi cannot afford the assistance, and then other district next to Sukabumi can help them, and then Jawa Barat, West Java government should help them as well. So this is the system that we made. Indeed, we have a lot of landslides in West Java, very remote area, but that community as well can work very closely. And one thing that we forget actually, in the law of military as well as police, that they can help the people directly. For this is the we have military and police. We can find in remote area in Indonesia, so they can do their job in terms of disaster. That's my response to Pak Agus, Pak Andri.
Thank you. I have an opinion, and I also give some lecture to the student on medical faculty. I have a concept. It's concept from my senior. We call it you are on your own. What does that mean? That the concept, it's we should build our local capacity for disaster response, because we believe, especially in the remote area, the government or the outside NGO or something like that, it's not will become soon. That's why we should have prepared our capability by our community in local community for 1 or 2 days, because we need preparing for that. We call our yo-yo, you are on your own in 1 or 2 days after disaster. It's only our dreaming that we or our local community we have opportunity to build our we call a safety community, that we can prepare our local disaster and we can survive maybe. And for example, our surgical community, if there is something happen in the site, we not only send a medical team, we also send an assessment team. The team is only assess how many operating theater it will be, it can be used for our cases. For example, for the Dustira Hospital, we have 8 operating theater, but during disaster, maybe it's only 2 operating theater available because no medical equipment, no nurses maybe. Like in the Haiti, there's so many doctors, but there's no nurses there. And also we can divide it, which hospital can do amputation, which hospital can do only debridement or something like that. That the team, our surgical team, only assess the room. Nah, that's our simple job, but it is very useful because don't think that like RSCM in Jakarta, it can be running for 20 operating theater in the same day and the same time. Maybe it's only 2 or 3 operating theaters there that we need assessment team. That's my opinion. Maybe Dr. Bagus, do you have some idea or some comment, please?
Yeah, thank you.
I'm so sorry for disrupting first. Dr. Bagus and Dr. Andre, I'm so sorry because Lou shall be leaving for Canberra soon. So would you give us some conclusions or closing remarks, Lou, for us? Thank you. I'm sorry for interrupting.
I'm sorry for interrupting too, and thank you, Dr. Silvi. And sorry, Dr. Bagus. I very much appreciated Professor Burton's, succinct presentation on what government is doing, because sometimes it can be confusing. We have a system in place, and then when the disaster hits, other people included in that system start to make, which can affect everyone around them. So my closing remark is, understand the chain of command. Let us not have a disaster on top of a disaster. Understand. Wow, am I really slow? Am I hearing myself? And
yes.
Am I really? Am I really bad? Isn't it? Okay. Really
yeah,
slow.
I can hear you.
Really. Okay. Okay. Having and thank you, Dr. for having me.
Well, thank you with you.
Thank you very much, Lou, and Thank you very much. And hope see you. Thank you very much. Hello and
ke satu acara lagi, jadi untuk lebih ada engagementnya boleh di bahasa Indonesia juga kita terima ada, kalau ada yang masih ingin satu acara lebih yang didiskusikan.
meteorologi karena kerusakan. Disebutkan places dan kemudian dan cepat, tapi kemudian cara yang kedua adalah prevention and promotion yang kita kerjakan low cost, efektif dan efisien serta sustainable. Kemudian untuk sesuai dengan arahan Bapak Presiden di Badan Penanggulangan Bencana adalah berfungsi koordinasi dan harus melindungi seluruh bangsa ini ya dengan cara meningkatkan public health resilience berupa prevention, detection, and response. Sesuai tadi disebutkan bahwa keamanan keselamatan rakyat adalah nomor 1, solus populi suprema lex esto, itu adalah keselamatan masyarakat yang diutamakan. Mungkin itu kesimpulan yang bisa kita dapat dari pembahasan dari pagi tadi. Waktunya saya serahkan kembali kepada Dr. Terry. Terima kasih.
Terima kasih banyak, Dr. Andri, atas acaranya dengan berakhirnya diskusi tadi, maka sebenarnya berakhir pula acara webinar kita pada hari ketiga ini. Semoga acara webinar ini dapat mencapai tujuannya dalam mensosialisasi FK Unjani yang baru, terutama dalam penanganan kedaruratan medis dan bencana. Mudah-mudahan acara ini menjadi titik awal dari berbagai kerjasama dengan berbagai instansi baik nasional maupun internasional dalam mencapai tujuan dari visi dan misi FK Unjani tersebut. Semoga kita bisa mencapai mandat yang telah diberikan oleh Bapak Kasat kepada Universitas Unjani, dan semoga kedepannya bisa dilakukan implementasi dari langkah-langkah strategis dalam bidang penelitian, pengabdian masyarakat, pendidikan, dan suasana akademis. Terima kasih banyak untuk Dr. Andri dan untuk para pembicara. Dr. Lu, mungkin Lu sudah meninggalkan tempat. Sampai jumpa untuk acara berikutnya. Mudah-mudahan ke depannya. Saya mohon maaf karena ada kendala teknis tadi, sinyal